Good morning. I'd like to call this reorganizational meeting of the House Aging and Older Adult Services Committee to order. Everyone should know that this meeting is being recorded and members and guests should silence all cell phones and electronic devices. Haley, could you please take the roll?
Madden,
Here.
Benham, Borowski,
Designation.
Carroll,
Designation.
Serrato,
Designation.
Harris,
Designation.
Khan,
Designation.
Kozarowski,
Designation.
Kruger, Parker, Powell,
Designation.
Prokopiak, Rivera, Smith-Waddell,
Designation.
Menser,
Here.
Brown, Gleim, Jones,
Here.
Kozak,
Designation.
Labs, Marcel,
Designation.
Nelson,
Designation.
Pugh, Razel,
Designation.
Schlegel, Stare. We have a quorum.
Thank you, Haley. Having a quorum and pursuant to House Rule 44, the committee shall operate pursuant to the standard committee operating rules. Those can be found in Rules 1C through 4C. In short, our committee has been reorganized and we're ready for business. Let me welcome everyone, both new and returning, to this first meeting of the Aging and Older Adult Services Committee. Overall, we have 9 new members on the committee. I look forward to working with you all as we maintain a very busy and productive session. Chair Menser and I try hard to make sure all of our constituents' voices are heard as we hold meetings and advance policy. Chair Menser, would you like to offer any early comments?
Thank you, Chair Madden, and it was a pleasure working with you last session. I'm looking forward to working with you and my colleagues to advance the benefits for older Pennsylvanians.
Thank you, and I'd like to mention that Representative Khan has joined us. We will now transition to our informational meeting on home and community-based services. As a committee, one of our top priorities is to ensure older Pennsylvanians have the ability to stay in their homes and age in place. But to best do that, we need to provide much-needed assistance to those individuals who provide care to our older adults. To that end, we have the good fortune to hear from 2 of our Commonwealth's leaders in home care who are no stranger to the committee. Mia Haney, who serves as CEO for PA Home Care Association, and Laura Ness, who serves both on Beata Hearts and Home Care as president of the board and directors of the PA Home Care Association. I would like to remind members of the public watching at home that many of our members serve on multiple committees and have the difficult task of trying to balance multiple committee obligations that are scheduled for the same time. So don't be alarmed if you see members coming and going throughout the meeting. Okay, ready. Good morning. Before we begin, I just want to mention that Representative Harris has joined us as well. Ladies?
Can you hear me okay? Wonderful. Good morning, Chairwoman Madden, Chairman Menser, and members of the committee. My name is Mia Haney, and I am the CEO of the Pennsylvania Home Care Association and also the Executive Director of the Association, of the Pennsylvania Association of HCBS Providers. Testifying with me today is Laura Ness, who is both the Deputy Executive Director of Bayada Hearts for Home Care, but also, more importantly, she is the President of the Board of Directors for the Home Care Association. So we're really thrilled to be here today, and we thank you all for your time. We want to speak to you on behalf of all of our members and provide insight into the vital role that home care plays in the lives of Pennsylvanians, especially the aging population and those who are living with physical disabilities. Our home care association and associations that we represent are nonprofit trade associations. We have more than 700 home care, home health, and hospice providers across the Commonwealth, and these agencies serve hundreds of thousands of Pennsylvanians each year, 300,000 to be exact. The essential care they provide is across all 67 counties, and it is our mission to promote the value of home care, enhance the quality of the services provided, and advocate for policies that ensure that home care remains a viable and sustainable option for all individuals in need of long-term care. As the leading voice for home care providers in Pennsylvania, we work diligently to advocate for funding, for regulatory policies and legislation that support the direct care workforce and the home care services that they provide, while ensuring that our members have the resources and tools necessary to provide high-quality care. So what is home care? Home care at its core is about providing compassionate, professional support to individuals in the comfort of their own homes and communities. It encompasses a wide range from assistance with activities of daily living, such as bathing, dressing, eating, to skilled services that could be provided in visits or in shifts. And those skilled services could be nursing care, physical therapy, occupational therapy, medication management, and more. Home care empowers individuals to remain as independent as possible while receiving the care that they need in a setting that promotes dignity, well-being, and has proven that it has improved health outcomes versus other settings. Importantly, home care is a person-centered service. This means that care plans are developed based on the unique needs of each individual, and the goal is supporting their independence, enhancing their quality of life, and preventing unnecessary costly hospitalizations or institutionalization. This requires a very unique relationship between the caregiver and the patient. And you may not see this relationship in a hospital setting or another facility setting where you have a relationship of one-to-many. This relationship is fostered and developed over many years, and it becomes one that is so personal and so memorable, and it leaves an impression on everyone who receives that care. So what do our members do? Our members at our associations are employers of more than 260,000 workers across the state of Pennsylvania. We have in the home care industry, there are more than 5,000 brick and mortar locations across Pennsylvania alone that are providing this type of care. So as you go through local counties and communities, you'll see our signs. You'll see all of the information across the state of Pennsylvania saying that we are all looking for direct care workers, that we are trying to enhance and reinforce our workforce. Our services range from short-term support for those who are recovering from an illness to long-term care for those who are living with a chronic condition or disability. And the providers, those employers that we represent, they are both large organizations and they are small mom and pops. PHA members and PA-HCBS members ensure that individuals receive care tailored to their needs, often in partnership with physicians, hospitals, and other healthcare providers. They're dedicated to enhancing quality of life by promoting independence and dignity. The lines of service within the home care industry is probably the most confusing aspect to someone who is new to the industry. And we've listed out all of those different lines, and we want to make sure that you explain them and that we explain them and that you understand who pays for each. So the first is personal care. And personal care services include non-medical assistance with daily living activities. So again, your bathing, dressing, meal prep, assistance with mobility. These services are critical for individuals who require support to remain in their homes and to remain independent. These can be paid for privately, or they can be paid for through Medicaid home and community-based services funding. This is primarily through the Department of Human Services. For the Office of Long-Term Living Programs, personal care services are referred to as personal assistance services. Medicare and third-party insurances do not typically cover these services, and that is a common misconception when somebody gets to a point when they need these services, is they'll call us and say, does Medicare cover this? And the explanation and answer is no, and coming up with funding opportunities for them is a challenge that each one of our providers face. The Pennsylvania Lottery has a fund called the Options Program, and it's for individuals who are just above the Medicaid eligibility and thus don't qualify for the waiver program, and they provide critical services for our members and the patients that they serve. Our Pennsylvania Home Care Association has also established a foundation, a nonprofit foundation, to collect funds to donate one-time amounts of care for people who are in need but don't have funding elsewhere. The next line of service that we have is private duty shift nursing. This focuses on providing specialized care to children or adults who are living with complex medical needs. It allows them to remain at home with their families rather than going to a hospital or healthcare facility. You very frequently see children or adults living with trachs or vent care at home and receiving this nursing level of care in the comforts of home. These are primarily paid for via Medicaid funding. Home health care is another line of business that we have. And I know it's confusing when you have home care and home health care, but please try to follow. Home health care includes skilled nursing services. So these are nursing, physical, occupational, and speech therapies, as well as some home health aid services. These are often medically necessary, and individuals are recovering from surgery, managing chronic conditions, or needing ongoing medical assistance. Home health can be paid for privately, but it's also paid for via Medicare, Medicaid, and most third-party insurances. We refer to these visits frequently as episodic. They are visits. Someone comes into the home, does education, completes their skilled care, and then leaves for the day. They're not typically delivered in shifts of care. And finally, hospice care. Hospice providers offer end-of-life care, focusing on providing comfort and dignity to individuals with terminal illnesses. The goal is to manage pain and symptoms and offer emotional and spiritual support to both patients and their family. Hospice can be paid for privately via Medicare, Medicaid, and most third-party insurances. So why care at home? That answer is pretty straightforward to us: to keep people out of facilities and to prevent costly medical care that could be prevented. We've got a number of other reasons that we've listed in our testimony today that we'd like to go through with you, but at the heart of what we do, it's keeping people where they want to be and keeping them as healthy as they can be. Workforce stabilization is a huge consideration for our industry. Wage competitiveness, which is the shortfall between the average hourly rate paid for home care versus other comparable jobs in other industries, in Pennsylvania fell to negative $3.36 in 2023 for direct care workers. We are among the worst in the country. The industry turnover rate is an average of 79%, and this signifies the need to increase pay rates to stabilize churn and to improve continuity of care for patients. Loss of staff to other industries has become an unfortunate reality. We are also facing loss of staff to contiguous states, where the reimbursement for these services is significantly greater than what we have here in Pennsylvania. Protecting access to care is one of the most important things that we do. Failure to adequately fund these programs, and by extension, this workforce, will result in movement of workers to non-competing industries: retail, food, drivers. The net result of this is people leaving the industry, and unfortunately, more than 112,000 shifts go missed each month. So these are shifts of care that are approved, that somebody is waiting for, and that they're receiving a call saying, I'm sorry, we don't have coverage today. Home care jobs support our local economies. As we talked about earlier, we employ more than 260,000 workers across Pennsylvania. We have more than 376,000 job positions posted annually, and this workforce is serving both rural and underserved areas as well as our urban areas. The growing demand, you know that story. We have one of the largest elderly populations in the country, with 1 in 3 Pennsylvanians expected to be over the age of 65 by 2030. This is a population of more than 4.3 million, and the need is growing. We strive for cost-effective care, and we deliver cost-effective care. To qualify for these services, an individual must be nursing facility eligible, meaning that they would not be, if they were not home, they would be in a nursing facility. In a cost comparison study conducted by Genworth, in-home care costs an average of just under $5,000 per month, compared to nursing home care at a rate of just over $10,000 a month. Additionally, through early intervention and close monitoring of patients, home care can prevent costly readmissions, exacerbation of illnesses, and complications, all of which are expensive to Medicaid. By rebalancing dollars from facility-based care to home care, we are saving money and controlling healthcare spending while still ensuring quality of care. It goes without saying that home care is the preferred setting. For many individuals and families, this is where they want to be for as long as they can be. We also noted earlier that there are improved patient outcomes when care is received at home in the setting of the patient's choice. So it's important that we continue to focus on driving the best health outcomes for the population that we serve. And we're supporting the non-funded holistic system of care. So often our providers are speaking with family members who are at a breaking point with stress from dealing with their loved ones and the care that they need, and trying to arrange the care, ensure coverage, and meet with caregivers, meet with nurses, meet with physical therapists, and introduce them to the dynamics of their personal home environments. Personal assistance services, which are primarily non-medical in nature, represent a significant portion of the home care services delivered to Medicaid recipients. These services enable individuals to live independently, reducing the need for costly institutional care. Medicaid, as you are aware, is the primary payer of these services, but it's also important to understand how these rates are structured. The Medicaid reimbursement rate for personal assistance services is set by the state, and it covers a wide range of costs for agencies. Unfortunately, the current rate is set at $20.63, which is insufficient to cover the true cost of providing care and to ensure that our workforce has the tools that they need to provide the best quality care and the full scope of care that's needed. It's important to note that the Medicaid rate is meant to cover the cost of many operational needs for our providers. Wages and benefits for the direct care workforce is of utmost importance. The direct care worker makes on average $13 an hour despite the critical nature of their work. And as we stated earlier, in other contiguous states, that rate is significantly different. Training and certification costs is also included in that $20.63. They need to do ongoing training, stay compliant with state and federal regulations, and the agencies incur significant costs to ensure that their workforce remains well-trained and skilled. And a large portion on compliance, quality, and administrative overhead. Medicaid compliance, Medicaid billing, state and federal regulations, insurance, quality assurance programs, all require resources. These administrative costs are necessary to ensure that the programs are run well. It's also necessary to ensure that we deliver the highest quality of care. But they further reduce the amount of funds available to pay workers. So as we continue to talk through reimbursement and specifically Medicaid reimbursement, it's important to note that agencies are forced to supplement their Medicaid-funded services through other means, including diversification into other models, other Medicaid programs that pay significantly higher. In Pennsylvania, the Office of Developmental Programs, the VA, and OMAP all pay more for a similar service than we are able to do in the Office of Long-Term Living. And that differential is significant across our own programs here in the state of Pennsylvania. The current reliance on other services and diversification of payers creates a difficult operating environment at best and contributes to the missed hours and inadequate service delivery options for participants. With that, I'm turning it over to Laura Ness to talk about our workforce shortages.
Good morning, and good morning, committee members and staff. I'm happy to be here today. And as you've heard already, workforce shortage is a bit of a theme today, and something that the industry has experienced chronically over the last several years, and it's only been exacerbated since COVID. So staffing shortages is a challenge to all of us. The Bureau of Labor Statistics reports that the average wage for a PA direct care worker is $13.35 an hour. And that is creating a struggle to compete with other industries who are hiring the same workforce, but for starting ranges between $16 and $18 an hour. You see this everywhere, from Uber drivers, at gas stations, warehouse workforce, retail stores, and more. This work is difficult. It is both taxing mentally and physically day to day. And with fewer individuals opting for caregiver roles, providers are forced to choose who should get care that day, because there is simply not enough staff to cover the current needs for all of us. For those fortunate enough to have other supports like family and friends, a lack of staff forces loved ones to call out of work or not sleep or not care for others in their home. And that jeopardizes their own livelihoods. And it also puts the Pennsylvania economy at risk, as these family members often end up losing their jobs and utilizing even more of Pennsylvania's safety net for themselves. This creates a quality and safety concern for our clients, and it jeopardizes the program's sustainability. Our aging population in general wants to age in place. We know this. It's preferable, and it avoids more costly facility settings. And when possible, which means that in-home caregivers are in high demand, and that is only growing. So our ability to pay competitive wages must be a critical priority for Pennsylvania. This becomes even more urgent when considering that neighboring states, as discussed, have reimbursement rates through Medicaid that are more than $4.50 than Pennsylvania. We cannot blame our workforce for crossing the border when able to go and do the same work that they love for much higher pay. We must enact policies that help keep jobs in Pennsylvania and support our most vulnerable population and workforce. So critical to any discussion about home care in the Commonwealth of Pennsylvania is Pennsylvania's Community Health Choices, or CHC program. This plays a significant role in how home care, home health, hospice services are delivered in the state. CHC is Pennsylvania's Medicaid managed care program for individuals who are over 21 and are eligible for both Medicaid and Medicare. The program was designed to provide an integrated and coordinated care for seniors and adults with physical disabilities. The CHC program manages long-term services and supports and home and community-based services, or HCBS. It aims to enable individuals to receive services in the home and other community settings rather than institutional facilities, which we know is more preferable, again, and of course, more cost-effective for the individual and for the state of Pennsylvania. Through CHC, the state has shifted to a managed care approach in delivering these services, with the goal of improving health outcomes, enhancing quality of care and coordination, and promoting greater access to home and community-based services, while enhancing cost predictability for state funding. For home care providers, CHC has been an important step to ensuring individuals receive care in the most appropriate setting, which we support. But it also introduces new challenges. One key issue is the sheer complexity of the program itself. With multiple MCOs operating in the program, there are varying levels of service delivery, reimbursement structures, approved processes, and this creates confusion for both providers and consumers. MCOs have different policies, procedures, and priorities, which leaves providers' concerns often lost in the shuffle. Additionally, the reimbursement rates for MCOs are most often tied to the current OLTL, or Office of Long-Term Living, fee schedule rates, which are set as a floor for rate setting for personal assistance services. MCOs often view the state reimbursement rates as reasonable and sound, as these rates are determined by the state and based off of a 2012 study that was over a decade ago, using 2011 and 2010 data. That is the rates that we are currently working with and working under. Only a handful of organizations of scale successfully negotiate rates above the floor, leaving a majority of providers unable to provide for the workforce adequately. However, it's also worth noting that CHC offers opportunities to improve care coordination and make Pennsylvania a national leader when the managed care approach was adopted. When administered correctly, this program can result in better outcomes for patients, particularly those with complex needs that require an intense amount of coordination. Overall, while the CHC program has provided an important structure for managing home and community-based services, it's still evolving and needs further refinement in order to ensure that it functions effectively with both providers and recipients, and is both funded and administered in a way that ensures these programs' longevity. In conclusion, home care is an essential and growing part of Pennsylvania's healthcare system and a healthy Pennsylvania economy. The services provided by our members not only help individuals maintain their independence and stay at home longer, but they also reduce healthcare costs by bending the cost curve and preventing unnecessary hospitalizations and institutionalizations. The Pennsylvania Home Care Association is proud to support the many agencies that provide these services, and we are committed to ensuring that the home care industry can continue to thrive and meet the needs of our aging population. As we move forward, it is crucial that we address the challenges faced by home care providers, especially in regard to Medicaid reimbursement, workforce retention, and ensuring the regulatory environment supports the delivery of high-quality care. We urge this committee to continue to prioritize home and community-based services in your discussions and to advocate for policies that strengthen and support this vital sector. Thank you all again for your time, and I look forward to working with you to ensure that Pennsylvania's home care industry continues to provide compassionate, high-quality care to all those who need it most.
Thank you so much for that valuable insight. We know from Governor Shapiro's Aging Our Way, the plan, the 10-year plan that they did, spoke to seniors, the folks who take care of them, that is the number one thing, right? Seniors want to age in place. We know it's better for their mental health. Just the idea of being able to get up and go somewhere for the day and see, people that you like and people that you can. My husband is a musician and his day job is playing in seniors' homes and nursing homes and day centers. So you've given us a lot of really good information here. The cost, what is the cost difference between home care services and, you did say it's roughly 50% more, right? Roughly $10,000 as opposed to $5,000. Can you talk about more specifically what it is about the services between the home health and being in an institution that would make it cost so much more, like the disparity? And also, before you answer that, I do want to recognize that Representatives Borowski, Representative Eric Nelson, and Representative Powell are here. Thank you.
Do you want to take that one? Sure. So one of the reasons that the home care industry and getting care at home costs so much less is because it is taking into account the care that is received in the home, but the other pieces are still harbored by the individual. They are in their communities. They are paying for their own food much of the time, and their electricity and their home, all of those pieces. So there is still community investment, and they are still invested in their community. Whereas when you're in an institution, and oftentimes these folks get put into institutions because it's the easiest place to go, quite frankly. There is an institutional bias still in Pennsylvania. It's easier. And whether or not you need these services, they're all inclusive. So oftentimes you are getting more than is sometimes necessary for these individuals. That's another reason to keep them at home, is to enable them to be in the community more, get them the services that they need, but not the services that they don't. They don't have to have the 24/7 monitoring. Many of these folks can operate in the home with 4 to 6 hours of care a day, something in the morning to get them up out of bed, get them breakfast, something in the evening to get them dinner, get them, be able to transition them back into the bed and sleep for the night. They don't need the 24/7 monitoring that you get in an institution.
And I would just add that technology aids home care in a significant way. Remote patient monitoring systems allow for coverage and monitoring of a patient while a home care aide maybe is not in the home, or in conjunction with the home care aide to ensure that we have the right supports. So we just, over the years, have found that we are a very cost-effective option for patients, and most importantly, we're preventing care. And I think that preventative care is a really important aspect. Collaboration and coordination is an extremely time-consuming aspect of how we deliver home care. You do a start of care, you're talking with a PCP, a physician. You're talking with their pharmacy because you're making sure that their meds are going to be arriving on time and that they're going to be in prepackaged packets.
packs,
Yeah,
or-
thank you. You're ensuring that the meds that they do have there, they're not confused about that the meds are the correct meds. It's ensuring that they're bathing even when they say they don't want to. I personally, and you'll hear me speak from experience, I should qualify that prior to joining the associations, I was a provider of home care services for 15 years in Pennsylvania. I could only, state that passion for the industry and for the people that we serve would drive you to continue to stay and continue to support this workforce and these patients, because very frequently it is just undervalued, the work that our providers are doing to support the managed care organizations and all the managed care organizations' work that they do for coordination, but also to support the patients and their families. Those family members call, and that home care provider knows them better than anybody else.
Thank you. We have a number of questions from members. Chair Menser, did you want to ask a question?
Yes, thank you, Chair. Have there been any studies by the Home Care Association on what the differential is between what currently is being paid to healthcare workers and someone being employed in a similar type role?
In the same industry?
Same industry or other industries with similar skills?
So the Bureau of Labor Statistics is a common resource that we go to when we're looking at wage comparisons on a regular basis. However, more recently, the Office of Long-Term Living and the Governor's Office commissioned a rate study to take a look at the wages, but also the total cost of care for personal assistance services. That rate study was conducted previously and was released in 2012. So this is the first time in over a decade that we will have a study like that. That study is currently under executive review, and we are hopeful and would ask for your support in pushing to get that executive review completed so that we can really review the results of that rate study and make policy decisions based on that data.
Has your organization done any study like that?
We have not commissioned a study like that to this point, but we'd be happy to consider that.
Okay, that's it. Thank you.
Next up, we have Representative Nelson for a question.
Thank you, Madam Chair. And I very much appreciate your testimony today. On another front, when you touched on workforce and available workforce, we've been really trying to work and better engage Pennsylvania's able-bodied workers, but within that same Human Services Department where, your organization resides, they're waiving that 20-hour-a-week work requirement for able-bodied adults. And so this is about 170,000 able-bodied adults that really would have an opportunity to get plugged in to employment and training opportunities, across the board. But we've really been struggling with, even to get census information about this population or ways to be able to get them. If we could get even 10,000 workers, back into the force, what would that mean to the home health care and facilities, that really could use some part-time extra hands to be able to get some of these unused licensed beds, back onto the rolls?
I appreciate that commentary. Any effort to further develop our workforce is one that we would encourage more conversation about. If there's been barriers to having those discussions, we would be happy to actively engage in those discussions. Our associations have invested in workforce development director, specifically to identify opportunities like the one that you just described. 10,000 workers would be a meaningful addition to our population. Again, we've got about 260,000 workers out there, but 376,000 jobs posted at any time. So the need is great. It would be a help, but we would still have more to do.
So would there be a way that, go ahead. Yeah.
I would also just add that a lot of the programs that are in Pennsylvania to get folks back into the workforce, home care providers don't qualify for because we are unable to pay the wage that is expected on that side. And that is primarily driven because of the reimbursement rates, which again are set by the state. So we're kind of stuck in this ugly circle of wanting to participate in more of these programs, wanting to get more folks into the workforce and utilize the current programs that are available, but not being eligible for them because we can't pay them what this work deserves and what the programs require.
So if we were able to try to create some type of a partnership or a training opportunity where some of these folks would, because it seems like our business communities and the long-term care communities aren't really able to get to that population of able-bodied workers, even to attempt to recruit them, like within the counties. I don't know how we bridge that gap, but it seems like maybe it's, something that moving forward because you could still provide those individuals with the services they need, but getting them working and earning, it's this cliff-based model that seems to be, that we're wrestling with. So
We would love to engage in conversation to open those lines of communication. The Pennsylvania Home Care Association for over a decade has been running a free online learning management software that is completely free to users to come on and do video trainings for home care services. We have more than 80 videos available to the direct care workforce, their family members, literally anyone who wishes to take them. And we are launching a new, I call it a facelift of the platform within the next few weeks. So we're really excited to be able to deliver that and maybe use that as part of how we train and upskill this workforce.
cool. Thank you, Madam Chair.
Thank you. I'd like to mention that Representative Serrato joined us, and we have 3 more questions. First, we're going to hear from Representative Benham, then Representative Brown, and then Representative Borowski.
Good morning, and thank you both for sharing with us today. I really appreciate it. This is definitely an area of legislative interest for me, and I'm wondering if you can talk a little bit about what portion of the rate that you receive from the state is going directly to the workforce, if there are any requirements around that, and what that looks like on average or specifically for your agency.
So as we stated earlier, the Office of Long-Term Living is currently has drafted and has that rate study that is up for executive review. Included in that was a provider survey that would have captured all of the data that you're asking for in aggregate to be able to accurately depict just how much of that rate goes to the direct care workforce. We believe, based on our projections looking at provider survey data, that an average rate of our workforce is nearing $17 an hour. So we are looking at around $16.50 to $17 an hour is our belief of what's going there. A large portion, not the largest, but there is a significant amount of overtime in our program today. The reason for that overtime is because of the workforce shortage. Our rate, the $20.63, is an all-inclusive rate, which means that any overtime needs to be captured within that rate, and it certainly drives up the cost of care for our facilities and our providers. So that is a huge consideration. There are other models of care, of this care, that have a separate overtime reimbursement. Personal assistance services for agency providers does not have a separate reimbursement for overtime. It is all inclusive, and it drives up our rates significantly.
I would also add, from a provider perspective, we aim to have as much of that reimbursement rate go towards wages and benefits as possible, because we already have, as Mia had said earlier, 79% of our workforce leave every year. Can you imagine having to essentially recruit for an entirely new staff every year, year over year? So we could allocate a lot more to wages and benefits if we were able to get recruitment costs down, if we were able to get some of the other administrative costs down, but that unfortunately is not possible with the current reimbursement structure as it is today. And that is one of the reasons why we are here, because we know they are going to other places, even though their hearts are in this type of work. It takes a very special individual to be able to go into someone's home, which may or may not be like you and I's home, right? You are going into some homes that are ridden with bed bugs and hoarding and some really not ideal conditions to deliver this critical care and life-sustaining care for these individuals. We want them to get every penny that they deserve. And unfortunately, we know that with the current structure as it is, it's just, we can only slice and dice so many ways before it gets down to wage. And that's unfortunately where providers are right now.
That makes a ton of sense, and I'm sure that I will see one or both of you in my office to talk about the things you like and the things you won't like in my legislation.
We always appreciate that collaboration. I would just also add to that that there is sometimes a misconception that agency and personal assistance service providers are not providing benefits or paid time off. And the reality is that the competitive landscape in Pennsylvania is such that it would be impossible for these employers not to be offering those types of benefits. Also, the Affordable Care Act requires any employer that is over 50 employees to provide those health benefits. And so there are many misconceptions out there about what is being offered. We have many providers that we've spoken to who have been creative over the past years to try to attract staff to their organizations that are offering 401k, that are offering really unique incentives for the amount of work that somebody does, AI tools to incentivize folks via text message to pick up shifts and gain points in order to get more dollars into their pocket. We are being incredibly creative to incentivize this workforce to take as much work as they will, and also to refer other people to the industry. Referral bonuses are a significant part of how we attract workers in home care. Thank you.
Representative Brown?
Thank you, Chairwoman, and thank you for hosting this panel. Thank you both for your testimony. It's very timely for me because last week I just met with a new provider in my district, and she is having to only accept private pay clients because she's not been accepted through a managed care organization. And she said she was rejected by UPMC, who told her that we had enough providers in our area, which is ludicrous to me. and she's not received any response from the other 4. So can you help me better understand how they get enrolled with these MCOs and
Yes, happy to.
yeah.
So in Community Health Choices, there are currently 3 managed care organizations, potentially with 2 more coming in time. The 3 organizations are AmeriHealth Caritas, which is known as Keystone in the Philadelphia area, Keystone First, as well as Pennsylvania Health and Wellness and UPMC. Currently, and Laura, correct me if I misspeak, but all 3 managed care organizations have closed networks, indicating that they feel that they have sufficient provider networks across the state. They have the opportunity to make exceptions to that rule, but we hear almost every day the same story that you've just indicated to us from providers who are interested in providing care that are struggling to get contracts with Community Health Choices. They have an opportunity to still be a Medicaid provider with the Office of Long-Term Living, but the programs that are outside of Community Health Choices are very small in comparison, and it simply cuts them off from the largest program that we have in the state.
I would say one thing we're also seeing across the state is that individuals who are taking private pay, their rates that they are charging for these families are higher in order to offset the very low Medicaid reimbursement costs. So this is becoming an issue of really further taxing the middle class and bearing the weight of some of the inadequacies on the Medicaid reimbursement rate side in order to kind of rob Peter to pay Paul and have a higher wage overall for your direct care workers, but it's on the backs of private pay or other programs that are more adequately reimbursed.
So how do we change that?
Well, we would need to work with the Department of Human Services and the managed care organizations to indicate what the need is and talk to them about the way that they manage their provider networks. In addition to having closed networks, we are seeing also provider consolidation, meaning that many providers are receiving termination notices that they have a contract today, but they will not have a contract. Typically, I believe it's about 60 days notice, which has, it creates a lot of turmoil for the customers who receive care through those providers because they have a caregiver who is now more than just a paid worker. This becomes a member of your family in many ways, shapes, and forms. They know that person better than the family members do sometimes. And that provider losing their contract means that that employee either needs to move to another employer who now has the contract and can accept the care, or the customer needs to pick a different caregiver within another organization. It forces the customer to pick a new organization, and it certainly has ripple effects in the community.
Yeah.
We'd be happy to talk more offline.
All right, thank you.
Rep. Harris?
Yes, good morning. Thank you, Chair. I'm noticing in my community, possibly a lot of other places, that senior home care is now, senior buildings is 55 on up now, And I think we missed the mark with all the passion through the election on single payer conversation. And this is the issue. The largest population in the country is aging out, the baby boomers, right? So we got to fix this. We got to get this right. With that being said, on the home health care, how much the Medicare pays or their private insurance, is part of that cost is it transparent to the homeowner that they may have a bill, like say if they pass away or, they come out of that condition or whatever, is that cost transparent to the homeowner that they may have a bill on their home?
So as far as delivering Medicare services, that's done through the federal Medicare program and is often covered under that. I think that's one of the great parts of that program is that, once you age into it, if you need short-term and acute services, then you are eligible for home care. But if you are in need of home care for a longer period of time, if you're in need of in-home supports on a shift basis or on a regular basis due to a chronic condition, et cetera, there is no federal program or state program that will pay for it unless you are Medicaid eligible. So none of that goes against, I would say, the actual home, because you have a lot of these folks who are renting in apartments or in maybe a family member's home that are currently living and residing there. It's done through and billed through Medicaid and the Medicaid system. And so their managed care organization would see those pieces on the Medicaid side. Does that help?
I'll just clarify. So home health and hospice services can be paid for through Medicare and third-party insurance. There should be transparency. If there is any copay, it's rare that there is. Home care services, which are non-medical in nature, not skilled, and happen in shifts of care, are not covered by Medicare and traditionally not through any third-party insurance. And so we rely on Medicaid.
Yeah. I mean, because I was a deputy register of wills, and some of these cases, some are the probate cases, right, that they didn't see that cost coming to them, like the inheritors of these properties, right? So they didn't see the cost. Although it was a child or family member providing the services, hired by these agencies, they didn't see the cost coming. So I'm just saying, even if there's a cost, it should be, I think, more transparency with that. Also, and I just wanted to ask you, you said $20.63 wasn't sufficient because we have, people going to other places, but you can't blame them. What's a comparable wage that they should be paid? And also, how does, if there's other countries handle this better than us?
Other countries or states?
Countries, like, you know what I mean? Yeah.
So I'm going to roundabout answer your question. Hopefully I'll get there. So just to give you insight on what's happening just in neighboring states, $25.44 is the reimbursement rate for the same service in West Virginia. $25.53, I think it is the rate in New Jersey. We are lower than every contiguous state by more than $4.50 an hour. So I do appreciate that there are folks out there who say that raising a rate doesn't substantially change recruitment and retention. When you say that, we're typically talking about raising a rate 25 cents or raising a rate 10 cents. The rate increase that's needed here and the reimbursement need that we have is far greater and will have extremely meaningful impact to Pennsylvania. And we cannot continue to kick the can down the road and not address this policy. We got here from over a decade worth of really pushing the problem off to the next year. It has to happen. We are in crisis. The crisis isn't coming. We're not planning for it. We are actively there. There are some testimony and videos from some of our members crying during COVID, crying after COVID because the competitive landscape changed so much that they are sitting in an office explaining to individuals who are literally just wanting a meal or a bath that they have no one to send to them, that there's literally they are in another customer's home providing care themselves and just trying to let them know that no one's coming that day. We are in crisis and we cannot afford to wait. Thank you. We will. Thank you.
Thank you. We have a couple more questions. Representative Rivera.
Hi there. Thank you very much for all of this information. Aging in place is a passion of mine. My family housed my husband's grandmother from age 98 to 107.
Wow.
Yes.
Congratulations.
She was miraculous.
That's amazing.
But navigating the process was quite daunting. And the turnover, we experienced a lot. And the no-shows for shifts, we experienced a lot. Mm-hmm. It's not a glamorous job. It's not something that a lot of people seek. But I'm wondering what the marketing is of this to the public. I know a lot of college students who will do it if they're going into healthcare fields, but I think the average college student might not know that this is an option. Yeah. So how is it marketed to people who could become part of the the workforce with this, but who might not know about it?
So I'd say one piece of that is marketed very heavily for across our industry is the fact that many of these hours are flexible. You are able to work as much or as little as you need, and that can be on a very flexible basis from week to week. There are also providers that really market that the fact that they pay weekly or even daily in some cases. So for individuals, which are many times living paycheck to paycheck, that is a key driver for them to be able to have that sort of predictability. And then I think the other really large piece that you don't necessarily see in the American healthcare system as it is today is that one-on-one interaction. Many folks get into nursing because they want to be by the bedside. They want to deliver patient care. And oftentimes what they find in hospitals and other institutions that it's more of a revolving door for them, right? They spend 5 minutes here and 5 minutes there, and they're just moving from room to room to room without ever really developing a personal connection and relationship. In home care, you are the one in the home. And it is a place to really hone your skills. Whether you be an aide or a therapist or a nurse, you are oftentimes in that setting alone. So you are operating with more competencies and more independence than you would ever see in an institution. And that's empowering for a lot of individuals. And it's really rewarding work in that sense as well. So we spend a lot of time marketing kind of those aspects of it. And, especially that one-on-one connection piece, because oftentimes we feel, we see that it's, you don't get that bedside opportunity that you once did.
I would also add to that, we were very fortunate last year to be the recipient of a Department of Labor and Industry grant that will allow us to provide training opportunities to 1,300 direct care workers, most of which are not in the industry today. Our focus in that grant is partnering with colleges, high schools, immigration centers, and other areas where we can drive individuals to this industry that aren't here today. So that is a critical component. And I would say if you've talked to any of our provider members, you will find many of them are catering to folks where they do not speak English. It's not a second language. It's just not a language at all. And so we have providers that are everything is in Spanish, Nepalese, Vietnamese, Russian, all of the, those are our top 5, I believe. But there are many more. And really, this is such a zip code by zip code business. The relationships that you make, being kind of that Main Street provider, that you're visible in that local community, that when they say take a left at the red sign and then a right at the, after the hill, and that where that is and what that means is all such an important piece of how we gain access to the workforce that we need to support these cases.
Thank you.
Thank you. Representative Serrato?
Thank you. It's great to see you. I apologize for missing it. I was at another committee meeting, the actual presentation, so I'm going to go ahead and look over this later. But I just wanted to thank you for your work. I know, I just recently visited one of the homes in which we have aides in my community, and I got to have really in-depth conversation with the aides themselves, as well as some of the administrators who joined and helped show me around. And it really is a huge issue. I mean, we know it's a huge issue. We know that Pennsylvania, the only population that's growing is our aging population, and we have to address this somehow. I don't know what the answer is for recruitment. Having been a person that worked in this field prior to getting involved in politics, I know the toll that it takes both physically, mentally, and emotionally to care for people. And you form a bond. So whether you knew them prior to coming on or not, it's really a difficult situation, but it's also such a necessary situation. And I don't know what the answer is other than, let's just throw all the money in the world at people and hope it sticks. But the reality is that alone is not going to fix the problem. We need to have it kind of coming from all fronts. And I don't know, for me personally, at $20 an hour to have gotten a college degree and have student loans to pay, this would not be a sustainable job to raise any kind of family off of. I know that you had said that they are paying for time off and that kind of stuff now, but I've talked to a lot of care workers who say that's not the case over the past few years. I don't know if it's a more recent change, but I'd be interested to find out if that is a, office by office scenario on whether or not they're getting paid, and figure out what percentage it is. But I know it was just a few years ago the reimbursement rate was much lower, so I know we've definitely made steps. We have a lot more steps to go, but any suggestions you have for us legislatively on how to move forward? We can all request studies over and over and over again. We all know that the Department of Human Services does not like change very much or very often. So we know that it's an uphill battle, but if it's a battle worth fighting, we need to know and have the means to combat it in the best possible way. So anytime you have stuff, please come and talk to us and let us know what we can do to help in this circumstance. Thank you.
Thank you.
Thank you. Rep. Schlegel?
Thank you, Madam Chair. I'll yield back. Thank you.
Thank you. I just have two quick questions. I heard you talk about community health choices. Do you work with a life program?
Many of our providers do. They are like a subcontractor of many of the life programs. So we are not a life program, in and of itself, but we work with those organizations. Absolutely.
Essentially supplementing their need for caregivers.
Yeah.
Right. Okay. And so when we have these hearings over and over again, we hear the analogy, our care providers are not making a sustainable wage and they can go make more money at Sheetz or Wawa or any of these other places. So can you tell me what exactly is the training that's entailed in becoming a direct care provider? And also, are we working? I know you said you spoke to a grant that you got from the Department of Labor and Industry. Are we training people in our career and technical schools? Are they coming out of our career and technical schools able to work in these jobs?
The training is primarily provided at this point by the employers, not coming out of technical school with that type of skill set unless they're going to school for some type of healthcare degree, in which case they can receive training at school and then get some education hours by working through one of our agencies. You had specifically asked about training. So the training requirement for the Department of Health, there are 16 competency areas that somebody needs to be deemed competent in prior to them starting care, and those 16 areas are consistent across all of the agencies that provide care. In addition, there are training requirements through the Office of Long-Term Living. Chapter 52 regulations, and those training areas must be met before somebody starts care. I would add to that we have a large number of agencies that are using those free online learning videos that we've created, over 82 videos, because supplementing and consistent training is a really important factor in how we are providing care. We also have providers across the state that have developed really excellent training programs in-house, where they have in their facilities training beds, Hoyer lifts, wheelchairs, gait belts, and can provide that hands-on training opportunity for our direct care workers that are providing personal assistance services. In some of the other programs, such as pediatric and adult shift nursing, and some of the other home health and hospice settings, there is a 75-hour training requirement, so it does depend on the program that you're working with.
I'd say that's one of the wonderful pieces about the home care industry is you can really start, it is a career ladder. You can start as a direct care worker or a homemaker and have kind of the most basic requirements, and then you can work your way up to a home health aide with that 75-hour training, and then on to LPN and RN. And we've had many individuals do that, and many organizations support those folks along the way. I can speak to specifically Bayada Home Health Care has has a nurse residency program that takes newly graduated nurses, and I know there's other organizations that have this as well, and they provide very specialized and intensive training on trach care and ventilator care, and get them to the point where they're able to and willing to deliver this type of very complex care independently in the home with the utmost quality. But again, all of that cost is harbored by the organization, by the business itself, and it all comes down to, where their funds are currently being allocated. So perhaps one organization may have just this phenomenal and very extensive training program, and in return they don't have a PTO program as a result. So it's all based on the need of that community and what they are seeing and what their employees most need, and what the individuals of the community most need.
I would just add that typically home care is the lowest paying per discipline, which means that if you have someone that you're supporting in skill building and they become a CNA, they become an LPN, they become an RN, if they want to stay in home care, that's typically the lowest rate that they will receive at their new discipline level. And so frequently we will upskill and we will see them leave for facility-based settings because they can make more money there, which is an unfortunate unfortunate result when you're trying your best to really improve and upskill the workforce and give them all of the opportunity that they deserve. And we would, really love the opportunity to pay them what those facilities can pay them.
Thank you so much. We have those conversations in this building too about our employees. We'd really love to pay them what they deserve. Are there any other questions? Seeing no further questions, I'd like to thank you for being here. I'd like to thank for all the members of the committee. And there'll be a committee. We'll be holding an informational meeting next Monday, February 3rd at 10 a.m. to hear from our local area agencies on aging. Thank you so much. Thank you, everyone.
We appreciate it. Thank you for your time.
Adjourned.
An important party to us.